by you folks, and others might think it's a bit sloppy. But especially the cognitive enhancing ones, they were small, and yet they showed some interesting differences. Maybe over like a year or something like that, just using them like cognitive enhancing agents. So here is the trial that we bravely undertook, and some of the folks involved. Funding from the Alzheimer Drug Discovery Foundation. ARC is our CRO.
Actually, just before you go on, why do the trial open label?
We debated that a lot, and then we decided that this is a trial that has to be very interactive with the family doctors. And we were trying to be neutral as to expectations, and that it would actually be helpful for them to know exactly what people were on. So they get randomized, but it's open label, and in discussing the design, Kevin Thorpe and so on, we decided that it wasn't a big advantage to not know what they're on. And actually, we're just still getting started, so we haven't got enough experience to tell you that, but at the moment it looks like it's fine because everybody knows what they're on. In some cases we have somebody, so what we do is if they're on a sartan, they're not included. I'll show you that in a moment. If they're on, let's say, Perindopril, they could get randomized to Perindopril or to Telmisartan, because our hypothesis is, as I'll tell you in a moment, is that we'll see a little edge for the Telmisartan versus the Perindopril. But we think they're both like first in class, right? Both, because Perindopril also has some history in the progress study where they looked at people who had a stroke, not even hypertensive, mild stroke, and then they were randomized to Perindopril or an indapamide and followed over time, and they showed, compared to placebo, that they showed less decline to dementia. But most of the dementia was vascular dementia. When they looked at the subset who had more of a neurodegenerative dementia, it wasn't so clear. It looked like it might actually have been a bit worse. But overall, there was a benefit. And also, their white matter disease increases were less. So these are the doses that we're using. Our sample size to try to find an effect, I'll talk about in a minute. And 2 years, we figured, would be necessary, and then 1 year follow-up. So here's what's a bit novel, and this is what you get to do when you like to use imaging as important biomarker of brain health. We're actually using ventricular enlargement as our outcome measure. Otherwise, we'd have to have hundreds more people. It's a well-studied global measure to track brain degeneration. And in prodromal AD, it predicts the likelihood that you're going to become demented. In our own pipeline, which we've designed over the years, we found that in Alzheimer patients in this sort of representative group, there's an expansion of about 10% compared to about 3 or 4% in age-matched controls. We didn't control exactly for the medication people were on. It was like a 1 year, over 1 to 2 years we averaged. So we didn't exactly correct for that because we were just trying to get some numbers. And we know that ventricular volume changes can correlate with MMSE, and these are some of the ADAS-Cog is a standard cognitive test used in Alzheimer's disease. The clinical dementia rating scale, sum of boxes, is widely used as a kind of a caregiver-patient interactive interview that now is sometimes the outcome measure of drugs that are going to be worth millions of dollars just to do them. They're using interviews with the patient and the family as a primary outcome measure. So we wanted to estimate maybe a 25% difference in ventricular enlargement, 80% power. We also have to take into account something called the ApoE4. That's that gene that makes you at risk for Alzheimer's disease and can affect your likelihood of getting it and progression rate and so on. So we're going to kind of look at that in all these patients as well. So this is what I'm talking about. This is a baseline Alzheimer patient, and I think you can see, maybe you can see better than I can, that there's a bit of enlargement there. This is a normal control, and that's a year later that's kind of age matched for that person, age and education matched. So that's why we thought maybe we could do a quick and dirty first proof of concept. We call it a proof of concept to see whether or not a bigger trial would actually be warranted. My original idea was we would kind of do this first in the tertiary clinics, and then if it looked promising, we'd have to go to family practice. to probably take this over and do it maybe in Ontario or somewhere and actually do an effectiveness, comparative effectiveness study in much larger numbers. So this was our primary objective, mild, moderate disease, because we wanted to, maximize. Like if you're MCI or you're prodromal, you don't see those changes so quickly. But once you start to get into the Alzheimer dementia phase, there's a burn going on. The brain is burning. The brain is dying, right? It's got like a 8 to 10 year course. And it's just going to shrink away, and the ventricles get bigger, and the sulci get bigger. Your hippocampus, just doesn't disappear, but it shrinks right down, and you're in trouble. You're in metastatic disease. So, maybe it was foolish to choose that stage, but to see proof of concept, we thought that was the best thing. So we just predict that there will be a significantly smaller increase in ventricular size, and that both will be well tolerated, and hopefully they'll be equally good in terms of their blood pressure control and the various side effects. Except we do know that if you're starting on an ACE inhibitor for the first time, you can get a cough, and that will, it doesn't unblind us. That was the other thing. We figured we'd be unblinded by a cough, but we might lose people that way. That's why we actually need about 200 to analyze, and we put in 240 for the coughers, probably. We're doing a whole bunch of other measures, looking at cognitive and functional change, hippocampal volume, all these things we can generate, and it's sort of par for the course that you have to do the ADAS-Cog and some of these things just to be even having a conversation in the field of Alzheimer's disease. We're also looking at neuropsychiatric measures just to get pilot data. We've got a whole bunch of other things we generate when we do a scan. We can generate a whole bunch of different acquisitions in the same hour we have to pay for, including structural integrity, resting state, all of which is sort of interesting to do in this subpopulation, all of whom have hypertension. And then we're also looking at caregiver burden and quality of life. Moving right along, these are the key inclusion criteria. We're trying to stick to what's considered probable Alzheimer's disease, allow one or two little lacunes, but not other kinds of strokes. They have to be on an antihypertensive medication, and the family and the physician willing to change it. Over 55, mini-mel state, 16 to 27. 8 years of education, they have to speak English, otherwise it's just too hard to do the testing. Stable dose of a cognitive enhancing agent for 3 months. Most people are on that now. They can't be too diabetic, and all the medications are meant to be stable for a period. They have to have a caregiver. They have to be able to undergo an MRI scan, but also to have had a scan done within the last 2 years, just so that it's not somebody who's got a whole bunch of strokes and is being called Alzheimer's disease.
Why do you need to be on a cholesterol?
Because most are. That was the reality. And it is, they do have an effect. So,
Do you look at how long they've been on it?
well, most people in this stage have been on it for a while. We'll look at that.
Yeah.
But it does have, I'm not sure it's going to affect the ventricles, although we've got some data suggesting that being on a cholinesterase inhibitor actually reduces the rate of enlargement of the temporal horns. So they may be active. So we're just trying to control that. And it's actually not an issue. I'd say once or twice we've had a few people who aren't on a cholinesterase inhibitor.
Yeah.
They're widely used.
Oh, no, I know.
It was just a control for...
about whether they should be as widely used as they are.
Well, we can have another conversation about that. We've done before and after studies showing that in a well-matched set of patients, as time goes out, they decline less fast. So, and they're, we didn't do propensity matching, but they're matched in every other way. Same center, all the rest of it. And significant differences in how they changed over 2 years, up to 2 years. So I think these drugs do help. The question is, when do you stop them, and other issues. This is just to show you the kinds of things that we're not trying to include, where people have a lot of white matter disease. It's just, because it complicates things. And this is the design. So they come in, and they're, screened, and they hopefully get in, and then they're phoned at 2 weeks. They come in at a month, And actually what's interesting is that they're keeping a daily record of their blood pressure, which is turning out to be quite interesting. And that's why they have to have a caregiver, come at 3 months, 6 months, 9 months, and 12 months. And they have a baseline MRI, and then they...
What's so interesting about their blood pressures?
Because some of them actually do vary at different times of the day. We had one guy who... Actually, it turned out there was partly a reason for it, because I think certain days when his wife was working, he was taking the pill later in the day, and his blood pressure was quite high in the afternoon, and not on the days when they were down. Now, that was something we could fix, but it's just giving us patterns. We take the average of their monthly blood pressure in the previous months to adjust the dose if we have to. Paulo is our clinical pharmacology and sort of medical collaborator who helps us. We've got algorithms for adding and whatever else we have to do, because it's obviously not my primary area of expertise. So this just shows you the various things we do. This shows you that we can also look at target areas of Alzheimer's disease. We can do cortical thinning. We have a pipeline that can do individualized assessments. We can look at the hippocampal volumes. These are the cognitive assessments and the various other things. And this is just to mention that there are 2 other trials underway now in England. So looking at losartan versus placebo in Alzheimer patients, normotensive or not. I mean, hypertensive or not hypertensive. So there's some thought that especially Telmisartan might actually also be okay to use without being hypertensive for its other effects. It doesn't necessarily bring your blood pressure down in a bad way. We even contemplated this, but we decided for ethical reasons that would be a little too far to push. Our review committee, ethics review committee, because it might be exposing people to hypotension, which we don't want to do. But in fact, they're doing this in England. And the primary outcome there is also whole brain volume. I think we had a little influence on what they decided to do, similar sort of number. And then in the US, there's a study that's going on using candesartan versus lisinopril for a year in hypertensive MCI patients of the executive subtype, not so much amnestic. And they're going to look at executive function. And then they're doing a biomarker study where they're looking at CSF pathology. I think they're also doing amyloid imaging in candesartan versus placebo in normotensive MCI. So you see people are starting to get bolder about using these drugs even as neuroprotective if you're not hypertensive. We just weren't bold enough to do that. So what I can tell you is it's been a real lesson in physician comfort zones, turns out, and also in practice change. So one of the practice changes is that in our region, at least a lot of Toronto, a lot of people are on sartans. It's very hard to find people not on a sartan. Secondly, the cognitive neurologists aren't really comfortable playing around with these drugs. Even if you give them kind of an algorithm and hold their hand and so on, no, it's not their drug. It's other people's drug. It's family doctor drugs or cardiology drugs. So they've not been too enthusiastic. Geriatric psychiatrists, actually one of the sites is a geriatric psychiatry site. The guy's just kind of more willing to do it. But even the geriatricians, so why would you play around with somebody's medications? They're supposed to be controlled, like, why would you do that, right? So we've run into problems with kind of uptake. And secondly, the clinics over the last few years are seeing fewer and fewer just Alzheimer patients because the family doctors are managing more of these patients. We're seeing milder cases, we're seeing worried well, we're seeing complex, chemo fog, and deaf and blind, and multiple comorbidities, and post-TBI, and maybe AD. I mean, complicated cases. So it's not as easy for us to find Alzheimer's disease. And this actually came out also on the Ontario Neurodegeneration Research Initiative, where we were just doing an observational study in AD and MCI. We had a terrible time recruiting the AD patients from the tertiary clinics. So a couple of things we've done. First of all, we've had to reach out to other sites across the country. And interestingly, there are some There are some stroke neurologists who are kind of interested, or they've ended up having to be interested in dementia because that's what's surrounding them in their places of practice more and more. And they're totally happy manipulating these drugs. They have no fear. They've had to learn to do it. They did it 20 years ago when you started to have to really weigh in stroke prevention clinics to take care of patients, right? So we have a site in Hamilton, Jim Salas, we have Eric Smith in Calgary, and then also at UBC, they're willing to do this, and they have a geriatrician who's been trained in Toronto who's quite willing to do it. So we've had to reach out. But most important is we've discovered a very important resource of the University of Toronto. It's called Utopian. Does everybody know Utopian? Yes? Okay. So there's a family health collaborative network. It's called Utopian. It represents 1 million patients. And it reaches up to Barrie and out to Ajax, and I don't know how far into Mississauga, but all of the University of Toronto academic centers are part of this. And they imported a Scotsman to start the database. And so they have, they're in the process of developing their database. They have about 200,000 records, and they're building. So we went to them cap in hand and said, hey guys, could you maybe help us with this? Like, could maybe find some patients that might be appropriate? We'll work with the family doctors. There's even, at East General, there's a family doctor who's happy to be a site and to be the site. So their deal is that they'll help you search in their database for appropriate patients, but also there has to be a family doctor on the steering committee. So we actually have 2 family doctors who want to be on the steering committee. One is going to be a site. And so we're just in the process of now contracts and arrangements to start to find things. They did a quick look and they found 150 patients who might be appropriate. And now we're trying to drill down through all of the different ways. There's a facilitator, and then they have to work with the sites. And we're hoping that that's going to be a source of patients that might be appropriate. So we've actually had to turn earlier than I thought. I thought eventually we'd show maybe proof of concept, then we'd hand it over to the family doctors to let them kind of do an effectiveness study. But, I mean, a bigger effectiveness study. But now we've had to turn to them just to get the proof of concept done. And so stay tuned, because we had to negotiate with the foundation to give us more time, to allow us these new attempts. We're also working with the geriatrics and family practice in University of Waterloo, and also in Lethbridge they're interested. So we'll take any help we can get in order to be able to do this. You have to have access to a 3T scanner, because you can do so much more at 3T in the same, like 40 minutes, 45 minutes of scanning. You can get a whole bunch of multimodal information. And there aren't too many studies that look specifically at Alzheimer patients with hypertension. And also we're going to generate some interesting information about the daily blood pressures of these individuals. So that's it. Now I don't know if we have any interaction from afar. I guess not. This is just... So any questions or comments, and maybe expressions of sympathy and good luck? And
we've got 2 or 3 questions. Dennis, you're first, and then Susan.
So I think it's fantastic. It's interesting. As cardiologists, like, we use these drugs routinely, and we kind of think that they're equivalent. But I just wonder, in your trial, whether it will be, I just wonder how important is that day-to-day or month-to-month variation of blood pressure in your outcome? Because I would have maybe think about a trial, fixed dose ACE versus ARB, or even if you think ARB is the best drug, ARB versus some of the blood pressure medication, then your difference would be bigger. And then you just give the dose, and the family doc can manipulate the other blood pressure. But you would have 2 doses, then you don't have to have your neurologist manipulate blood pressure.
Well, no, I mean, essentially what we're sort of doing, and in fact, in one of the sites said he's okay to do the algorithm and start, like, there's a way depending on their kidney function and age and so forth, we have to start with low and then go up. Excuse me. So that's essentially what we're doing, but we have to have some way to bail out if they're really not controlled, right? Might be that depends on what they start with. And by the way, we don't stop drugs for heart disease like calcium channel blocker or beta blocker, right? So there's some rules within what it is we can manipulate. But if it is a matter, I think we just had out of a small number, like 8 patients or something. We've had one person where we were concerned about the blood pressure at times, added a small dose of hydrochlorothiazide in agreement with the family doctor. It will depend a little bit, if it's a patient of yours, then you can work with the family doctor and suggest it. If not, in one of the sites, they're going to suggest that the family doctor consider it. But I think the assumption is that these are equally pretty good as antihypertensives. So that's not the main issue. It's just that we, under our watch, we don't want somebody going way above what's appropriate.
All right, Susan, you're next. Then
Wait,
you might
wait.
have the last question.
Yeah, I guess it was more of a comment as you were talking as to whether there's anything supportive we can think about with the ISIS data holdings. But I guess we're challenged a little bit by any kind of incident dementia as an outcome. Obviously not with your image-based outcome. But I guess I was just mulling when you cited the
we did want to
VA
think about
study.
that. I mean, in fact, I think we're also interested. Jody Edwards, I don't know if you know Jody, is working with Moira Capel. I think we're trying to look at even just stroke outcome or stroke. I mean stroke severity at incident. At first arrival in the hospital, using the stroke registry, which was kind of an ISIS thing, right? To see whether there's any difference in, let's say, severity of baseline onset, just kind of, because it's like, I don't know, a couple of 100,000 patients, I think, in the registry. Just to see if there's anything at baseline that would be of interest. We'd love to look at dementia, but it's just a question of how well you can define that, right? There are some ways of guessing it, but.
Yeah, I think that was sort of
And you could link hypertension and kind of. Yeah. So, I mean, if there are any ideas you have to kind of look at that. What we did with the ADNI data set was exactly that. We took at baseline people who were on SARTANs versus other drugs and just looked at some of those features, like their brain atrophy and their baseline level. And now we didn't find it in Alzheimer patients. When you looked at the whole group, the normal controls and the mild cognitive impairment, it looked like they were in better shape if they were on a SARTAN in a way that was significant, which was kind of shocking to us, because that's just like 800, it was like 800 people, 200 were Alzheimer's. And the Alzheimer patients are already in trouble. So, there may be some more information there through population studies.
Yeah, population, right? Because we've got the resident assessment instrument data on that, which is not a perfect measure of cognitive impairment, but at least would give us something about what we could do with traditional assisted.
Yeah, I mean,
But
yeah, I think any way that we could figure out how to just see how people are doing versus, with the ACE inhibitors versus a SARTAN, would be welcome.
Okay.
So thank you very much for your attention, and I hope you've found it sort of an interesting